Welcome to part 1 of this intensive masterclass on renal clinical reasoning. I am Dr. Claude Renaud, Adjunct Associate Professor and Senior Consultant Nephrologist at KTPH. Today, we are going to dive deep into the very logic of nephrology. We aren't just here to memorize facts. We are here to build a structural framework for your thinking that will serve you throughout your medical career. We have a comprehensive curriculum to navigate, moving from the internal psychological barriers of nephrophobia to the critical importance of modern clinical reasoning models. Let's begin by addressing why this field often feels so abstract and how we can bridge that gap by connecting fundamental biochemistry to the clinical bedside. Our goal is to transform how you approach every renal patient you encounter on the ward, moving from intimidation to analytical mastery. The challenge of nephrophobia is well documented in medical education. Undergraduates are frequently overwhelmed by the intricacies of renal physiology, hormonal cascades, and complex electrolyte imbalances. This isn't just an anecdotal feeling. Statistics from Singapore show that nearly half of medical students and residents express a documented phobia toward nephrology, ranking it as one of the most feared specialties alongside neurology. By acknowledging this fear, we can begin to dismantle it. We must move beyond the too complex label and see the kidney as a logical, predictable biological system. Understanding these barriers allows us to focus on the clarity and precision that nephrology actually offers when approached with the right logical tools. We must turn the fear of the abstract into an appreciation for the precise science. A significant focus group study identified 6 major themes that serve as barriers to a career in nephrology, including a perceived lack of advances in the field and the overwhelming complexity of patients. To navigate this, we must master the 9 Entrustable Professional Activities, or EPAs. These include managing diabetic kidney disease, nephrotic syndrome, and complex electrolyte dysfunctions. By focusing on these core competencies, we transform the barriers into a structured learning path. Each EPA is a building block in your journey toward clinical excellence. We want to show you that the reasoning required for these tasks is some of the most elegant and satisfying in all of internal medicine. Mastering these EPAs is the first step toward overcoming the perceived barriers of our specialty. When do learners actually decide to join our specialty? Data from fellow surveys show that for many, the decision happens late, often during the 2nd or 3rd years of residency. For U.S. medical graduates, nearly 48% make the choice during their residency years. This suggests that as clinical exposure increases and the logic of the kidney begins to make sense at the bedside, the perceived complexity transforms into a deeply rewarding professional challenge. Our goal today is to provide you with that light bulb moment much earlier in your training. By mastering the reasoning process now, you move past the intimidation and into the early mastery of the specialty. Consistency in your learning journey is key to this professional transition. Let's look at the models that define this clinical mastery. Clinical reasoning is the deliberate process of determining which diseases are causing symptoms. Using dual process theory, based on Daniel Kahneman's work, we understand that experts rely on System 1, fast, intuitive pattern recognition. However, as students, you must master System 2, the slow, analytical, and conscious path. Critically, this logical process is enhanced by empathy and compassion. Empathy is a cognitive attribute that allows you to understand the patient's inner experience, while compassionomics shows that caring makes a measurable difference in clinical outcomes. By integrating empathy with your System 2 analysis, you gather more accurate history and build the organized illness scripts that will eventually make your System 1 safe. This balance of logic and compassion is what defines a master clinician. Inconsistency here leads to diagnostic error. Even the most logical mind is vulnerable to thinking traps. We must recognize the different types of cognitive biases that can lead us astray. Anchoring occurs when we stick to an initial diagnosis despite new information. Confirmation bias is the tendency to ignore disconfirming data, and perhaps most dangerous is premature closure, accepting a diagnosis before it has been fully verified. To combat these, we use active regulating strategies. We must maximize every patient encounter, think of differentials early, and always practice thinking aloud with our mentors. Practicing metacognition, actively asking, is my thinking correct? is essential for safe practice. We must also rely on formative feedback. Alongside these strategies, practicing self-care and maintaining your well-being is a necessary adjunct to good clinical reasoning. Consistency in these strategies ensures your continuous professional growth. This concludes part 1 of our masterclass. We've explored the psychological barriers of nephrophobia, the milestones of choice in our specialty, and the critical integration of logic and empathy in safe practice. We've identified the barriers and established the strategies to overcome them through structured reasoning. Join me in part 2, where we will apply these foundations to real-world clinical cases, uroscopy, and advanced functional diagnostics. Thank you for your focus and your commitment to clinical excellence. This journey from theory to bedside is what defines our profession. I look forward to seeing you in the next session. Farewell. And remember to master these foundations before proceeding to the clinical application phase of our curriculum. We will see you very soon.